to remind everyone that this session is not mental health therapy, and we do ask to please don't ask for specific mental health advice and avoid sharing really deeply personal information during this. So we've started recording. So hello, everyone. My name is Amanda Haleman. I'm the National Manager of Mental Health with Breakthrough T1D. And on behalf of Breakthrough T1D, we would like to welcome you to our series tonight. We're really looking forward to sharing the information that we have on the mental load of type 1 diabetes this evening. For those of you that might not be familiar with us, Breakthrough T1D is a global leader working towards a world free from type 1 diabetes through research, funding, and advocacy. We support people and families in the T1D community from the time of diagnosis by helping those living with T1D to have a better, healthier, and safer life while we work to find cures. I'd like to start with a land acknowledgement before we dive in. And as visitors on this land, we would like to begin by respectfully acknowledging that although this session today is virtual, I'm located in Barrie, Ontario. I'm standing on the traditional lands of the Anishinaabe people, which include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. We also acknowledge the Wendat Nation, who previously occupied these lands. Breakthrough T1D's research and activities take place across the land where many other Indigenous inhabitants live, from coast to coast to coast. We acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations peoples who call this land home. And I just wanted to provide a quick overview of the education series. So we do offer the education series on a new topic, which generally runs every other month. However, we do have a break for summer, so the next education series event will actually be taking place in the fall. If you do want to find other ways to engage with us, we host a virtual connection series on the fourth Wednesday of each month. So this is just an unstructured opportunity to connect with others. There isn't any formal programming. And the next connection series will be taking place on Wednesday, June 24th at 12 p.m. Pacific and 7 p.m. Eastern. Just before we begin, I've mentioned this a couple times before, but please do keep your microphones on mute, and this will be recorded, so turn off your camera if you don't want to be on video. In terms of engagement, there is a raise hand button that you can click. If you need any clarification, you're welcome to raise your hand, or we also encourage you to use the chat function, and there will be time for Q&A at the end, and we will do our best to get to them. We'll also provide a contact email in the chat if anyone has any comments or feedback from the session. So talking about mental health, so I'm the National Manager of Mental Health, so I've been really invested in this since I've begun my work with Breakthrough T1D, and we've known for a really long time that people who live with type 1 diabetes are at a higher risk for mental health challenges, and these are often not addressed in routine diabetes care. Up to half of adults with T1D experience diabetes burnout, which is often linked to long-term diabetes distress. And we know that mental health and physical health are very closely connected. And when you have mental health challenges present, we often tend to see worse diabetes outcome and more complications. Since we launched our mental health strategy in 2023, Breakthrough T1D has been focused on training mental health providers in diabetes care and developing new resources to support the community and healthcare professionals. Most recently, we've launched our Caregiver Guide, which is a downloadable resource designed to support parents and children of youth living with type 1 diabetes, as well as to support their own mental well-being. Tonight's discussion will explore the impact of type 1 diabetes on mental health and address some of the psychosocial burden living with T1D. It will also share approaches to help you and your loved ones better navigate the experiences for both adolescents and adults. It is my pleasure to introduce our speakers tonight, Zoja Anders and Dawn Davis. Zoja holds a master's degree in social work from the University of Montreal and a psychotherapist permit issued by the Ordre du Psychologue du Québec. She works in the medical psychiatry department at the CHUM and has developed expertise in mental health interventions in the context of diabetes. Dawn is originally from British Columbia and holds a master's degree in social work from McGill University, and she has worked with the diabetes clinic at the Montreal Children's Hospital since 2008 with youth and their families. I will now hand it over to our speakers.
Hi there, everyone. I'm Dawn, And I'm going to start us off today. As the social worker at the Montreal Children's Hospital Diabetes Clinic, I'm going to be focusing the first part of our talk tonight on a family perspective, and specifically a family of an adolescent. So I'll start by using a fictitious case example to try to highlight some of the ways that adolescent development interacts with type 1 diabetes and family dynamics. And then we'll also talk briefly about the impact of type 1 diabetes on parents or caregivers, and think about ways to preserve family well-being during adolescence, given the added challenges that type 1 diabetes brings to a family. In the second half, Zosha will focus on diabetes distress in the context of an adult, with lived experience. So we're going to start off today with a reminder of self-compassion, to forgive yourself for not knowing what you didn't know before you learned it. I am going to introduce you now to Nicholas, who's 15 and lives with both parents and his younger 11-year-old sister. He was diagnosed with type 1 diabetes 6 months ago and seems to have adapted pretty quickly. Parents were both involved initially in all the diabetes care and have been trying to convince Nicholas to start on an insulin pump, which he's definitely not interested in. One of Nicholas's parents has been having difficulty sleeping, difficulty concentrating at work, and is regularly looking at their phone to follow Nicholas's blood glucose data. The other parent is worried and frustrated about how stressed their partner has become, and also frustrated and angry with Nicholas for not being open to starting the pump. So there's been this building of tension in the home between Nicholas and his parents recently. This week, Nicholas's mother notices that he didn't give his lunch insulin at school. By the end of the day, she's frustrated, increasingly worried, and scared. And so she says something like, "How could you have forgotten your insulin?" Then she goes into how he would be so much better off on a pump and all the risks associated with missing insulin. Nicholas responds angrily, telling his mom to back off, accusing her of spying on him. His father gets upset with Nicholas for yelling at his mother and reiterates how useful the pump would be and how much better it would be for him. Following this, Nicholas decides to remove his parents from following his blood glucose levels. His parents regularly check in with him with reminders about injections, inquiries about blood glucose levels, and Nicholas just responds, "No, everything's fine," and seems increasingly distant and withdrawn. His parents feel stuck, and Nicholas feels like his parents only focus on the diabetes and that they don't see him as a full and complete person anymore. So, moving on to adolescence, I just want to make a quick clarification that we're going to be considering what we would call like typical adolescent development in this discussion, as there are many other important factors that can impact on adolescence and behavior, which we will not be discussing tonight. So, generally speaking, as per child developmental experts, adolescence is a time of significant brain development, and these developmental factors can lead to conflicts between parents or caregivers and an adolescent. Some of these features are risk taking or experimentation, that idea of magical thinking that nothing bad is going to happen to me, pursuit of autonomy, influence of peers, the search for identity and to fit in, to be accepted, while at the same time detaching from or distancing from parents or caregivers. And the needs of type 1 diabetes are such that there's an important role for parents or caregivers in supporting their teen, which can seem to kind of clash with autonomy seeking. Type 1 diabetes pulls the teen towards their parents or their caregivers, making the practice of distancing from their home base kind of complicated. Living with type 1 diabetes makes the teen different and can cause them to stand out, like that beeping technology or having your cell phone in class where maybe other classmates aren't allowed necessarily to have their cell phone, while your teen may just want to assimilate. So all this leads teens like Nicholas to have to make choices. As well, adolescents' ability to conceptualize long-term risks or long-term outcomes as not yet fully developed. So motivation is more in the immediate. For example, the benefit of spending time with my friends might be more important than changing my catheter right now. I can delay changing my catheter or giving that insulin injection at lunch, so I can just go join in on the fun over there. We can also presume then that many of these behaviors in adolescence are explained by these normal developmental factors. So while it may not be easy to navigate as parents or caregivers, Nicholas might just be responding according to his development. And so it's our job as caregivers, parents, pardon me, and the diabetes team members to adjust our response and efforts to be supportive to a teen like Nicholas. And so how this might have looked for Nicholas that day at school look, I missed this dose and nothing bad happened. Plus, I don't want to have to do it. My parents, my doctor, they keep nagging me, and I want to exert some choice here. Also, no one else has to do this, and doing this makes me miss out on time with my friends, and it makes me stand out, and I just want to feel normal sometimes. So also just to add, I'm not discussing this evening about diabetes distress here, but it's important to note that Nicholas might also be weighed down by the burden of the day-to-day care of type 1 diabetes and just needing like a break. So he could be seeking to escape the stress caused by those constant demands of managing his type 1 diabetes. And so not giving that lunch dose could also be a way of coping by avoiding it. Thanks. So changing directions a bit, let's consider how this diagnosis might look for a family. Each family member has their own process of coping with a type 1 diabetes diagnosis. There could be action mode, denial or avoidance, grief, anger, fear, guilt, helplessness, and so on. And given that each individual member of a family is adapting or coping in their own individual way, the risk is that two members of a family may not understand each other and may be confronted by the other's reactions, which can increase stress in an already emotionally charged environment. The impact of this diagnosis on the mental health and well-being of young people living with type 1 diabetes, as well as their parents or caregivers, is quite significant, or it can be significant. And much of the focus and services offered within the pediatric settings are more on the youth's reactions and adaptation. That being said, psychological distress in parents or caregivers after a diagnosis of type 1 diabetes in their young person can affect things like family communication, increase family conflict, decrease effective parenting abilities, and impact on child or youth adjustments to type 1 diabetes, as well as have an impact on parental mental and physical health. The next slide, please. Type 1 diabetes can be tough on family relationships, affecting how partners interact, intimacy, and sibling relationships. And as an aside here, how is Nicholas's sister living all of this? There's so many other topics and elements to discuss this evening, and we're focusing on a very narrow window, but the impact on siblings is a topic in and of itself. The constant stress and worry might leave parents feeling exhausted, unable to sleep, and struggling to think clearly, on top of the pain of losing a normal everyday life. So Nicholas's parents, like most parents or caregivers, arrive at a medical facility as concerned caregivers, likely having noticed symptoms in their child or teen, and then they left with a new diagnosis and several new roles: a triage nurse, a nutritionist, an endocrinologist, and a frontline crisis worker on a 24-hour shift. Parents and caregivers are conditioned by the treating diabetes team to triage for ketones, for hypos, to navigate sick day management, and basically start thinking like a pancreas, which could lead a parent or caregiver to lose sight of the bigger picture and my child as a whole person. We basically ask you to be in action mode from day one. So then how do we find a balance? So recently, I had the opportunity to hear a psychologist from Mexico, who also is a person who lives with type 1 diabetes, speak to the international pediatric and adolescent diabetes community in a conference last fall. And she asked us to consider time and happiness rather than only time and range, that medical measurement of how often blood glucose levels are in range. So I ask you, is this something you've considered, the idea of time and happiness? And also, how do you find a balance between time and range and time and happiness? Type 1 diabetes requires parents and caregivers to find the right balance between healthy medical and emotional well-being of each individual and the family. And how do we get there? Pardon me. Thanks. Your teen still needs you. Pardon me, even if that's not necessarily the message you're getting. It may seem to also contradict parts of their development that we just discussed. It's about exploring within your family how to shift towards an open communication and collaboration, if that's the barrier that you're facing. So if we use a general example of frequent reminders, did you change your catheter? Did you give your insulin? Did you pack extra snacks? Do you have rapid sugar on you? Which all might be helpful to your teen. In my experience, when asking teens with type 1 diabetes about whether the reminders are helpful, the answers vary widely. Some answer, yeah, I find it helpful. Others, the answer is very quick and no, it's not helpful at all. I already did the thing that they're reminding me about, and it's just annoying and it's just pissing me off. To, well, sort of, sometimes it's helpful and sometimes it just makes me mad. So a starting point to try to figure all this out could be to would be to sorry, I hear someone to be to self-reflect on the function of these reminders. Who's the reminder for? Is it actually a helpful reminder? Is there another way I can be helpful? Is the reminder to soothe the parent's worries? Is the reminder meeting the teen's needs? Taking a moment then, or longer if needed, to notice your worries before approaching your teen. So there's a need for self-regulation there if those worries are really high. And then validating with your teen whether your reminders are actually helpful or are the reminders inadvertently shaming or frustrating to your teen. So the idea for Nicholas's parents is first regulating their emotional reactions and then opening up a discussion with Nicholas about what would be helpful for him. And if this is a new concept in that family, letting Nicholas know that they're trying to do things differently and being patient as Nicholas gets used to this new way of doing things and being prepared for his responses, allowing for those responses and reactions as they could be reactive. And so also that takes more self-regulation on the parent's part. In following through with this kind of self-regulation and self-reflection, there is the potential to have some change in the family dynamic. So if we revisit that day in question, Nicholas comes home from school. His mother has already noticed the blood glucose levels were quite high, noting that he had missed an insulin dose, and she has taken some time to self-regulate and reflect on how she wants to approach him. Hey, Nicholas, how was your day? You mentioned you had a project due. How did that go? So his parent is engaging in a conversation about other priorities and parts of his life and seeing him as a whole person. I noticed your blood glucose levels were running high all day. How did you feel? Using empathy, regulating your worry. And a little note here is of awareness would be that Nicholas is possibly expecting an attack from his parent, given past interactions. So he needs time to adapt to these changes in how his parent or parents are interacting with him. And then going on with, I imagine it might have been a hard day. You might have felt pretty crappy. You have a lot on your plate. It's a lot to manage. And I wonder if there's something I can do to help with all you have to do on top of your the diabetes management. I have a few ideas that might help. Would you like to hear them? Okay, maybe now isn't a great time. We can figure out a better time and sit down and see how I can be helpful. And then it's also a chance to repair from previous tensions as this shift is his mom is making this shift. I'm thinking my efforts to be helpful haven't been so helpful, and I want to find a different way of being supportive. And I'd like to work with you on that, and I want to hear what you have to say. So this takes time and patience and consistency with your teen and with yourself. And it's okay if you don't always get it right. And you can name that and own it and move forward. And even say something like, oh, I'm sorry, Nicholas, that wasn't a very helpful moment. I'm still working on this. Thanks for being patient with me. And that is it. Thank you all for your time. I'll move it over to Zosha.
Thank you, Dawn. So
Thanks.
let's transition from adolescence to adulthood. And in the second part, I'd like to touch on two topics that tend to be related to diabetes distress. The first one is glycemic perfectionism, and the second one is device distress. And these are topics that I tend to see a lot in my day-to-day in the sessions. And so I think they're really important to talk about. So to do that, I'd like to introduce you to Sophie. She's 34 years old and she's been living with type 1 since adolescence. She's been using an insulin pump and a CGM for several years now. And according to her care team, her blood glucose levels are within target most of the time. But for Sophie, it definitely doesn't feel that way. She starts her day by checking her blood glucose before even getting out of bed. If the number is not exactly what she was hoping for, a cascade of thoughts is triggered. What did I do wrong? I should have known better. I've ruined my day. And this pattern repeats throughout the entire day for her. She checks frequently, she reacts to small variations, and she makes rapid adjustments, but it never really leads her to feeling reassured, even when she's with the target. And in the background, there's this constant pressure. As soon as the numbers drift, even slightly, she becomes anxious and highly self-critical, as if she's failed at something she should be able to control. By midday, she feels exhausted from what she calls hundreds of micro decisions that she has to manage. Her technologies are both a source of safety, but they also feel like a leash. The data never stops, and neither does she. She sometimes wakes during the night to check, just in case. She's also increasingly aware of the visibility of her devices, the alarms, people's looks, the feeling that her body is never entirely her own. When asked how she's doing, she tends to reply, "I'm doing everything right, but it never seems to be enough." So what do we see in Sophie? What do we observe? Sophie is definitely engaged, she's very conscientious, and she's responsible. And these are real strengths and qualities. There's probably very little that her care team could criticize because Sophie works incredibly hard every day for her self-management. And yet the result is a sense of deep exhaustion. She's constantly vigilant. She has this inner tension that she can't shake off. And her mind has become fatigued from always calculating, anticipating, and correcting. And rather than helping, all these checks and all these adjustments are actually making her feel worse. She's feeling drained and she's increasingly anxious. And to top it all off, she's really self-critical when things don't go as planned or as she would have liked. So those initial strengths that we pointed out have actually gone into overdrive. Sophie is holding herself to very high and fairly rigid standards for her self-management. She's aiming for an almost perfect ideal for her outcomes, and that ideal is frankly unattainable. She's also internalized language around good versus poor control, good versus bad numbers and results. And the result is that her experience every day is that she's either succeeding or failing. There's no middle ground, not very much nuance, and it leaves her very little room to breathe. And over time, her sensor data has become kind of like a report card or a performance report on the quality of her efforts as a patient. And I'm going to go even further and say it's like a silent judgment of her self-worth as a person. When she's in range, she feels temporarily relieved. But when she's out of range, that's where she becomes self-critical. She feels a lot of guilt and a sense of incompetence. And even though she knows rationally that blood glucose is influenced by all sorts of factors that are beyond her control, she always comes back to the same conclusion. If it's out of range, it's my fault and I failed. And when someone puts in as much effort as Sophie does and the results don't follow, it's incredibly frustrating, totally discouraging, and frankly, it's unfair. It doesn't make any sense. There's no logic to it. But that's the thing. And as you very well know with type 1, sometimes it doesn't make sense. It can be unpredictable. And it definitely doesn't always cooperate, and it can be tricky to figure out why because you've done everything right. So when those numbers don't follow and you've done everything as you should have, in that kind of health context, the more a person holds themselves to high and rigid standards, the harder it becomes to tolerate variability. And that's where distress can settle in and intensify over time. And so then there's this vicious cycle that kind of settles in. So the more Sophie aims for perfect numbers, perfect results, and the more pressure she puts on herself, well, the more she has to check and adjust frequently to reach those standards. But the mental load is going to become increasingly heavier. And with that, there's going to be emotional and psychological exhaustion that's going to build. The more that builds, the less she's going to be able to tolerate variability, which is inherent to type 1D. And her inner dialogue is going to become more and more harsh over time. And this can lead her to think things like, I'm putting all this effort, I worked super hard, it never works. What's the point of continuing to try? I'm not gonna get it right. And that's what diabetes burnout, or in any case, a very high level of distress can look like. There can be a lot of helplessness and despair when it comes to the results and future and how things will progress. So what is Sophie really struggling with? She isn't just struggling with her glucose levels. She's also struggling with what those numbers trigger inside of her based on how she interprets them. So she feels fear and anxiety, she feels frustration and discouragement, and she feels a sense of failure. And her way of reducing her distress is to try to control things even more. So her logic becomes, if I can control my numbers perfectly, well, maybe I won't feel anxious anymore about long-term complications. Maybe I won't feel frustrated that sometimes type 1 is unpredictable. But in the reality of type 1, as we were saying, where unpredictability and limits to control exist, this struggle, the struggle where you're always trying to control more and more, can become unhelpful over the long run. Because the more she tries to control everything perfectly to avoid discomfort, the greater the cost for her. It's costing her energy. She's feeling very, very fatigued, almost exhausted. It's costing her in freedom. And also, it will eventually cost her in quality of life. So the first question I have for you, and that I'd like to throw back to the group, what kind of relationship do you have with your numbers and your data? How would you describe your internal responses? Like, how do you talk to yourself? What kind of thoughts emerge when you check your blood sugar? Do you see yourself in Sophie? Has the relationship become very competitive? Is it filled with conflict? Is it hostile? Or are you ignoring each other? Is there denial? So there can be all sorts of ways of qualifying your relationship. I'd invite you to kind of leave with that question after today's session, because the cool news is that relationships can be worked on, and we can tend to them. So what can we do if you recognize yourself in certain elements of Sophie's experience? It can be interesting to think about the relationship. And I've said this before, there are a few things that I will assert with certainty. Everything's open for discussion except what I'm about to say. Your blood glucose values are in no way a reflection of your worth or your quality as a person. Blood glucose is physiological information. It is captured at a specific moment in a specific context, and it's used to guide action. Think of it like a light fuel, the fuel light on the dashboard in your car. When the fuel light goes on the dash, it doesn't mean you're a bad driver, and it certainly doesn't mean you're an awful person. It's a signal. It's saying, it's time to stop at a gas station and fuel up. So in the same way, an out-of-range glucose value is not failure, and it's not a verdict. It's information. It's an indicator. So from this perspective, and especially for your mental health in the long term, I'd like to propose separating or unhooking your self-worth from these numbers, creating some psychological distance between these two elements. And so how can we do that? What I'd like to say about Sophie is that she's very fused with her thoughts and her inner dialogue. So that means that she experiences her thoughts as if they are facts. So when she thinks, my numbers are bad, I'm so useless and I suck, it feels like an absolute truth to her. She believes it, and she experiences all the painful emotions that come with that type of thought, like shame, frustration, and discouragement. But a thought is nothing more than a mental event. It's something the mind produces automatically. It can be words, images, memories, judgments, or any kind of internal narrative. But it's definitely not, they're not facts. Thoughts are not facts. So your brain produces thoughts. That's its purpose. Just like your heart produces heartbeats. But what's pretty cool with the brain and our thoughts is that, contrary to, your heartbeats, you can choose the attention that you give your thoughts and how you respond to them. Think of your thoughts like a car driving down a road. It appears, you see it, it makes noise, you notice it, and then it continues on. So the problem is when you get into that car and you let it carry you away. So how can we create distance from our thoughts? How can we take a step back and create that psychological distance I was talking about? So Sophie is very fused with her thoughts. So what we want to do is defuse. And defusing is not about forcing yourself to think positively or convincing yourself that everything is fine if it's not the case. It's about learning to take that step back. So if you were to have the spontaneous thought, just like Sophie, oh, my numbers are bad, I suck, and I'm never going to get this right. Try using language as a tool to help you create distance. So you could say something like, I'm having the thought that my numbers are bad and that I'm worthless and I'm never going to get this right. We can go even further and say, right now, I notice that I'm having the thought that my numbers are bad, that I'm worthless, and that I'm never going to get this right. And so keep that in mind for after the session, and you can practice. And I'd invite you to observe your inner experience and if it makes a difference when you use those words to create that step back. The idea is that distance would allow the thoughts to have less hold on us. And it helps bring those numbers back to their real role. It is information that guides action. It's not judgments that are meant to attack your self-esteem and exhaust you. So we can take it to the next slide. And this is another really important theme. So Sophie's experience definitely highlights this. It's a major aspect of living with type 1D in 2026. It's this constant relationship with the body and with technology. And technology has indeed transformed self-management. There's more safety, more precision, more insight into the body and into outcomes. But for some people, technology has also brought about psychological and social challenges. The first one is how to deal with the constant flow of data. Now, let's remember, Sophie is grateful for her devices. They help her, they protect her, she feels reassured. But at the same time, it's as if the diabetes is never quiet. It's manifesting through alarms, vibrations, sounds, numbers, and curves that are constantly reminding her that it's there. So even when things are going well, part of her attention remains captured. She's anticipating the next alert. She's checking, adjusting, comparing, and sometimes when there's no real urgency to do so. And so this constant stream of data has actually become for her quite mentally overwhelming. And it's created an internal conflict. So on the one hand, she finds the technology helpful, but on the other hand, it keeps her in a near constant state of hypervigilance, which has become exhausting for her. And now let's also talk about the shift in her relationship with her body since introducing this technology. Whether it's the sensor, pump, or insertion sites, this all requires frequent handling. And that can cause discomfort, itching, it can cause pain, leave visible marks. And for her, it's as if her body is no longer just a natural support for life. It's become a technical space that she has to manage, monitor, and optimize. And so it's almost like for her, there's something kind of mechanical and robotic in her experience. And this has affected her body image. It's definitely affected her sense of freedom. And it's creating the feeling of being different from others, right? Because she's wearing these apparatuses. And speaking of others, devices are sometimes visible even when you'd rather be discreet. It's not always possible to do so and to hide everything entirely. So these apparatuses are revealing your medical condition to the world. And it's one thing, and it might be a bit easier when it's loved ones, family, or people you trust and that you can have honest conversations with. But it's another thing when it's colleagues you don't know that well, or a new romantic partner, or even strangers. So it can be very complex to deal with the visibility, the unwanted attention, and that can lead to feelings of embarrassment, anxiety or stress, shame, the fear of being judged or treated differently because these things are visible. So let's revisit Sophie's struggle. Again, she isn't fighting the technology itself. She appreciates it. She is struggling with what these devices make her feel. Shame about feeling different from others, stress and embarrassment. She feels discomfort. She's frustrated about the loss of spontaneity in her day-to-day. And also she feels fatigued from always having to manage these devices. To cope, again, she's turned to greater control. She wants to control what she shows, who she shows it to, what she hides, when she hides it. And her logic has become, if I control perfectly my data, my body, my image, my devices, maybe I'll feel less anxious, less different, less trapped by my condition. Or she may begin to avoid certain situations. So to not feel anxious or to not feel distressed. So she could avoid new relationships completely. She could avoid managing her care in certain public spaces. But as we saw earlier, trying to control everything comes at a cost, especially when it comes to variables over which we in fact have little control. So it's going to cost her in energy. And as we saw, she's increasingly exhausted. It's going to cost her in freedom. Her life is going to become more and more restricted, especially if she starts avoiding certain experiences or certain social situations. Her actions are driven by a desire to not suffer rather than by her values and what is important to her in life. And it makes sense because we don't want to suffer. And I'm the last person to say that that's not legitimate. But what do we do when the problem cannot be fully controlled and when we cannot eliminate it completely? And that relates to many aspects of type 1D. So that's when we can get stuck in that unproductive struggle I was talking about. So let's ask ourselves, and these are some questions I'd like to leave you with and that you can take home after our session today. And so they're on the next slide. When you feel emotional or psychological discomfort, what do you generally do to get rid of it? And is it costing you in energy, in freedom, or in quality of life? When you hide, are you moving closer or further away from the kind of person that you want to be in relationships? And what I'm inviting you to consider today is this. When suffering is present, choose consciously how you act in alignment with your values and what truly matters to you in life. The suffering may still be there, but this way you're moving in a direction that is meaningful to you. And perhaps then your body will no longer be experienced as an enemy that you need to fix or that something's wrong with, but more as kind of an imperfect companion in a life that matters to you. So there we are. Thank you very much. I think we've lost our PowerPoint. But that's okay because we were finished.
Okay, so it looks like, thank you so much for that. It looks like someone may have inadvertently taken control of the presentation.
Control. It's control.
Yes, it is. Carol, stop. Carol, if you could stop sharing, just click stop sharing. Hang on, I'm going to share and I'll kick her off. Hang on, there we go. Okay, I think that did it.
Yes, thank you very much. All right, so we're going to move into our Q&A period. So as a reminder, you can, we do have, sorry about that, just muting that participant. We do have one question in the chat that we'll start with. We have a couple of hands. So our first question is, what if there are people in our family or healthcare team who treat our blood sugar / HbA1c as a performance report? What if they criticize us harshly for it?
Dawn, did you want to comment? And then I can
Yeah,
I
mean, I don't know what the context is in terms of if you're in a pediatric or an adult setting, but the first thing that comes to mind with that is that that's got to be that's really unfortunate, and that really adds on. That's the distress caused by your healthcare team or your family. The thought that comes to mind is there an ally within your team, somebody that you feel safe with to be able to have that kind of discussion with, and that ally, that person, whether it's a nurse or a nutritionist, or in an ideal world, every team has a social worker. I don't know, or a psychotherapist. I don't know that that's the case. I know that's not the case, but that ally within the team would be able to not just speak with your team, but also to sensitize them to the approach. But also potentially to be able to speak to the family members who are inadvertently just packing on all this shame and unnecessary pressure. That's what comes to mind. I don't know, Sasha, if you had any other thoughts.
What could I add to that? I think my experience from also working on like training and having that discussion with health professionals is they mean well. And it can happen that they don't realize that that's the dynamic that sets in. Because their obsession is with the numbers, and they forget that if they focus too heavily on the numbers, it's actually quite dehumanizing for the person with the lived experience, and that there's so much more than type 1. I've had people come into my office and as a social worker, and they're giving me their A1C, and I'm going, well, I don't need that. I don't even know what to do with it. And they go, well, I'm just so used to that being the first thing that I'm asked. So I know it does take courage to do it, but as Dawn was saying, I think just voicing that and kind of reminding healthcare professionals, like, can you ask me how I'm doing? Or even, if it means preparing for the appointment and noting down, it's like, today I really want to let them know that I'm feeling anxious, and having that key word and saying there's something really important I want to talk about. Here's what I'm feeling. Also, in my experience, that sometimes healthcare professionals are afraid to talk about mental health because they don't know what to do with it. Once the person opens up about how they're feeling or their distress, the healthcare professionals won't really know what to do. But there's we're building a lot of awareness around that, and referrals can be made to social workers, psychotherapists, psychologists. There are resources out there. The directory was mentioned. So I think it's a question of kind of finding that courage to advocate for yourself and to just kind of put a few words out there and then see how the other person responds to that. They might, I'm my hope is that they would respond positively, maybe even be surprised and rectify, say, whoops, I didn't mean to make you feel that way. So yeah, that would be what I would add to that.
Great, thank you. And in the chat, Rosalie has put a link to the Mental Health and Diabetes Directory, where you can seek professional support from a provider that's gone through training in diabetes, as well as a link to our peer support program. Stefan has a hand up. You can go ahead and unmute yourself and ask your question.
I do. Good evening. I am an old-timer type 1. I've been type 1 for 30 years, and I've talked to a lot of type 1s throughout the years. And I've realized that a lot of type 1s that have had a rough patch or some kind of bad, low event seem to be carrying scars, myself being one of them. And I've tried to talk to different doctors about if there's any research or any work being done for, PTSD type treatments for type 1s who have had a life-threatening event. And the answer always seems to be no, and that surprises me. So I'm wondering, is there more information or is there more thought in that area of mental health that's being discussed behind the scenes?
Can I jump in on that one, Don?
Yes, please.
Yeah, I'm sorry to hear that, Stefan, and yeah, it's disappointing for that to be kind of the initial response, because definitely PTSD related with a severe episode of hypoglycemia is absolutely something that can occur. I think coming back to professionals who are trained, who've been through the training program with Breakthrough T1D, who have a better understanding of the reality and what it represents if there was a life-threatening event. So it's like super important to explore, especially if there's a fear of hypoglycemia that's developed as a result of that. So anything related to severe anxiety, PTSD, there are absolutely psychosocial interventions and psychotherapeutic interventions to treat that and to work on it. It exists, as you were saying, kind of behind the scenes. I guess it can be tricky to find, a professional who's trained and who has a complete understanding of it. But by all, absolutely, there are absolutely effective interventions to work on that.
Okay, excellent. So if I look through the directory, hopefully I would find someone, because I've and sorry to make this about myself, but I think it reflects a lot of thought in the community. A lot of professional mental health professionals are used to working with the mental burden side of things, and that's great. It's great resources to have, but the rest is rarely talked about. So I'm happy to hear that it's part of the curriculum.
And I think even I give you kind of a piece of advice to even help the professional in front of you. Let them know you'd like to talk about, things like, the experience of the diagnosis. Was that traumatic? Did the person arrive at the ER in a coma? Was it difficult to resuscitate? Sorry, if French is interfering here. Was that a traumatic event? Who was around? Was the person alone? Was there support? How did they react? How did they pull through? So even offering to talk about those events, to communicate the importance of them and the fact that they may have led to certain psychological difficulties afterwards. You can even kind of hint at the professional that those are really important pieces of information if there's trauma.
Excellent. Thank you.
And one thing I would also recommend, Sean, is when you are seeing a provider and you're looking through the directory, a lot of them do offer kind of 15-minute consultations. And I think finding someone who's a good fit, kind of explaining what you're looking for, is something to really think about. And a lot of them will even kind of explain in their bios the kind of approaches that they use, and the different kind of modalities and techniques. So finding someone who kind of fits what you're looking for. Hopefully, I really do hope you find someone.
Thank you.
You're welcome. Next, we have a question from Gail. What do you recommend in the situation of being an adult person with T1D who has to give multiple injections, sometimes with children present?
Well, I mean, I think that happens quite regular. I'm wondering what for me, I would think that you are you would spend some time like normalizing it. I'm wondering if this is a parent in front of their own children or a grandparent. But to be able to normalize it for kids, kids are very adaptive and they go along kind of if there's a lot of emphasis put on shame or that this is something that we should be hiding, kids might get a bit disturbed by that. But if we just say this is normal, a child might initially, if somebody's had a reaction, they might initially be like, oh, I don't want to see that, and they don't have to watch, but they could also, I think just normalizing it for that's sort of without knowing the whole context, I would say that it's a situation to normalize. Does that make sense?
It does. And Dawn, would you say like answering the child's question? You're the child. I'm turning to Dawn because she's the pediatric specialist. Answering the child's questions in an adapted way.
Yeah. I don't know if that answers your question, Gail, but.
Our next question is sort of a follow-up to the criticism of high blood sugars. So, do you have any advice for those of us who are on the receiving end of severe family criticism for high blood sugars and or complications of diabetes and medication side effects?
So that's like that's the same question we responded to before. So this is a really heavy part of the experience. Wow, yeah.
I don't know if we mentioned it earlier, Dawn, but I'm kind of feeling inspired when you mentioned to identify an ally, someone that, is trustworthy, and perhaps preparing with that ally how to communicate. Sometimes when it comes from a third party or someone else, maybe there can like some teaching. There's an opportunity for teaching if the family members are open to either participating in an appointment, sitting in, or receiving perhaps printed material or psychoeducational material. Perhaps some things could be communicated by the treatment team so that you feel like you have support and that it's not always you having to defend your point of view or defend your efforts.
Yeah, I mean, in our context where we work in a family systems kind of model, like that's like a day-to-day, we're working with a family, maybe an adolescent shares with us, this is happening. So we get their permission and we speak with whoever it is that maybe I have a nurse with me, depending if it's something nutritional related, the nutritionist and I might meet with them and try to help them without shaming the caregiver who's obviously coming at this from a place of concern and they think they're doing something helpful. It may not feel like it certainly doesn't come across as helpful, but that's their intention. Maybe you could invite them to view this recording.
Cool idea.
Yeah.
There's a response. I'm in adult care for context.
Oh, it's in adult care. Yeah. Yeah. So it is it's more of an individualized care model, but there still is that. I mean, Zosha, you can speak to that, but I think there's still space for that.
For sure, if they're willing to come to an appointment, if they're willing to participate and receive, and if they're open to receiving information, just because it sounds like perhaps their understanding of certain elements is not complete, and there's perhaps some like missing information or lack of comprehension on certain aspects of the self-management. So that could really help if it's a printed document or if it's a health professional giving the information, it'll have a different impact.
Our next question is asking if there's any resources for older seniors that have been recently diagnosed, as many doctors deal with children and younger people?
I do know, like in my practice, I work with adults, so 18 and plus. So I know that a lot of the resources that we tend to refer to are kind of for adults, generally speaking. Should Amanda, should I go ahead and
I
name a
put
few?
one in.
One link. I'm going to share a
Okay,
link.
perfect.
Yeah,
Actually,
I put in a link for the Platinum Club that Connected Emotion does. This is an excellent club for 55 and older, and for people living with diabetes and aging, and they go through all aspects of diabetes and aging. It is a once a month, and as somebody was writing there, Anna was writing there that she also part of the Platinum group, and it's very nice. As I work in peer support, I always tell people about the Platinum Club who come to requesting peer support to break through T1D. The Platinum Club is really doing great stuff, and they get quite a bit of people involved. So I do recommend that because it's specifically geared, and they do live things and on video. Yeah.
Whoops.
Oh, somebody's on.
yeah. Right.
So I think it's a great resource, and there is a personal aspect to it. It's not just
Thank you. I did pop a link in the chat of this actually quite newly discovered resource. To be perfectly transparent, I have not actually explored it, but it's called T1D 200 Aging with Type 1 Diabetes. It's not a Canadian resource, but hopefully that is useful to you. And if you do find it useful, feel free to email us and let us know what was most useful for you, because that would be really great for us to know. We do have a follow-up about exposing children to needles in general due to the possible association with needle use, which might be dangerous for them. If we normalize seeing needles used, might kids be more likely at a certain stages to use the wrong needles due to exposure to insulin needles?
Okay, so definitely there's a safety is paramount. There, depending on whatever age they are, the needles shouldn't be something they have access to. This is something more that I think a nurse would probably be really good at helping respond to, but like there's a disposal, having the needle disposal bin, so that I think that's the responsibility of the adults in the home to ensure that the kids don't have access to it. I don't know what else kids would be using needles for, so I don't think there should be play with needles. It's really not about letting them practice or anything. It's unless they have type 1 diabetes themselves, and that's a completely different topic. But I think that absolutely, like, if they're witnessing someone, I maybe misunderstood the question. I assumed it was like to help expose them to kind of being witness to injections, but for sure they shouldn't be having access to needles. I agree with you that we don't want them using it and then playing and harming themselves. Definitely. I don't know, maybe that helps clarify that.
I don't know if she was asking maybe about using needles for drugs, intravenous drugs, being exposed to needles and then intravenous drug use. Is that what you're talking about, Gail? I'm not what it seems like a leap, but I don't know if that's what.
I probably wouldn't be able to respond to that.
Yeah,
I don't have that expertise.
Yes, that's what she's asking about intravenous drug use after seeing exposure to needles in general.
Okay.
I've never heard of anything like that.
Yeah, nor have I. Yeah, I would say that you can just explain, like, whoever you are in relation, grandma or mom or whoever your auntie has a health condition, and this is how I take care of myself. This is how I keep myself healthy, and it's just for me, or something like that. But yeah, I couldn't speak to. I haven't heard that risk connection.
Thank you. We don't have any more questions at the moment in the chat. If anyone wants to add questions, we just got one come through. This is just a comment on
yeah, that's nice. Yeah,
using medicine. Yeah.
And I see, is it okay, Amanda, if I comment? I see there was a recommendation in the chat just for work on trauma, on hypnotherapy. And so I think that My main recommendation, there are different types of treatment in psychotherapy to treat PTSD and other forms of trauma. And it's worth, speaking to the professionals, seeing like how they work on the trauma. There are many credible approaches. Yeah, so I would recommend kind of like reading about the different approaches and making sure you find someone who is really a licensed professional. That's super, super important. So someone who is comfortable working with trauma, who is licensed, who's trained to work in mental health and diabetes, and then making sure that you're comfortable with the type of approach they're using.
Right. Our next question is, how can we deal with burnout when we can't really take a break from T1D? I've had it for 31 years.
Yeah. There's no breaks, no vacation, no remission periods, and then periods of symptoms, just like other medical conditions. So this is a really excellent question. My first question tends to be, is there an opportunity to seek support? Because diabetes, burnout, and distress responds really well to psychosocial interventions. So, if you have the space where you can work through the burnout and better understand what triggered it, what specific aspects of self-management and the day-to-day and lived experience of type 1, are there specific triggers? How can they be worked on? And so that break you're seeking, it's tricky because the type 1's not going to give you the break. But in that relationship I was describing and seeing how is type 1 like integrated into your day-to-day, is it taking up a lot of room and burning you out, or is there space for your other social roles and for you to invest those as you wish? So I think that my first response to how can we deal with is by seeking support to really do some introspection and better understand it and find healthy strategies to work through it, and to build protective factors also to prevent relapse. But it is, and I think what's actually quite inspiring in the work that I do with people, I've been exposed to so many different experiences, is that it's a condition where you have to cultivate motivation over the long term every day, and that's something that is so hard to do. And it's not easy to motivate yourself to deal with something that you didn't want, or that's very difficult, or that feels is an incredible burden in the day-to-day. So I think that the fact that you have to stay motivated to do your self-management on a daily basis over the long term, it's kind of expected for there to be periods where you will feel distressed and burnt out, especially if you have other psychosocial stressors in your life, divorce, loss of a job, any other life event can make the type 1 self-management more difficult. Dawn, I don't know if you wanted to add anything to that.
I think that's well answered. Thank you. I think, yeah.
All right, so we're close to wrapping up, so we have time for maybe one or two questions. So we have one. My granddaughter is 7 and was diagnosed at 5. How do you prevent development of eating disorders as she grows up?
Yeah, and as a grandparent, that you're a step removed from the influence, only that you can be a positive influence. It's a very tricky, and we know it's a big risk factor for people living with type 1 diabetes, especially young people. I think that the family environment needs to have a good, healthy balance around how we talk about food, just or not putting emphasis too much on restriction. There's a lot of attempts to manage blood sugars through certain types of foods. I think that would be really important. Obviously, I don't know how involved you are, but for the parents to discuss with if they're noticing concerns, or if they're feeling concerned about how do we, if they have the same question, to speak with their care team about any recommendations they have. It's really that it's a really great question. I don't have an easy answer for you, except that there has to be a really healthy discourse around food, and not tying the food. Although food is so connected to influencing blood sugars, our clinic's sort of focus is to say that If you're using exercise, it should be for fun. It shouldn't be to be managing blood sugars, so that the youth doesn't connect diabetes with having to exercise, so that they have a joy to exercise rather than feeling obliged. And the same with food, that we want food to be seen as, you're growing, you need all different types of food in order to have a healthy body, and just avoiding using food as a way of control.
Thanks
So
so
really,
much.
yeah.
All right. Well, thank you everyone so much for joining us today, and a special thanks to Zoja and Dawn for your wonderful presentations and answering those questions. We hope that everyone found the talk informative and engaging. We do appreciate any feedback so we can continue to provide you with content that's both helpful and supportive. If you are looking for more information, you can visit the mental health section on our website at breakthrough-t1d.ca. And like I mentioned, if you're looking for professional mental health support, you can visit our directory of registered mental health providers that have gone through additional training in diabetes, which is at directory.breakthrough-t1d.ca. Thank you all so much for joining us today and for being part of the conversation. And if you did need any more information, you can email us at mentalhealthstrategy@breakthrough-t1d.ca. Have a wonderful night, everyone. Thank you.
Thank you. Take
Thanks,
care.
everyone. Thanks a lot.